In this presentation, we will be discussing spina bifida, more specifically its etiology, mechanisms by which the condition affects development, its impact on the body functions and structures, as well as its impact on activities and participation. We will also discuss assessments that can be used with this particular population and evidence-based interventions.
Spina bifida is a condition that affects the spine and is usually apparent at birth. It is a type of neural tube defect. Basically, what happens in this condition is the neural tube doesn't close all the way. So the backbone that protects the spinal cord doesn't form and close as it is supposed to. This often results in damage to the spinal cord and nerves and can occur anywhere along the spine. The damage that results may lead to a range of physical and/or intellectual disabilities. Typically, the severity of disability depends on the size of the opening and the nerves that are affected. The exact cause of the neural tube defect is not fully known. However, it's believed to be somewhat complex and likely a result of an interaction between several types of causes. The first of these being genetics. There are many genes that are suspected to be involved in this condition. However, the most studied of these is the MTHFR gene. This gene provides instructions for making a protein that is involved in processing the vitamin folate. The next potential cause of spina bifida is nutrition. It is suspected that an insufficient intake of folic acid during pregnancy can contribute to the baby developing spina bifida. Lastly, it's suspected that environmental factors may also play a role in its development. Some examples of potential environmental factors include the mother being exposed to high heat during pregnancy, such as being in a hot tub or a sauna, the mother having diabetes or obesity, and the use of anti-seizure medication during pregnancy.
Spina bifida can happen anywhere along the spine. These incomplete closures often result in damage to the spinal cord and nerves. Spina bifida might cause physical as well as intellectual disabilities that can range from mild to severe. The severity often depends on the size and location of the opening in the spine, and whether part of the spinal cord and nerves are affected. The most common type of spina bifida is occulta. Within this type of spina bifida, there is a small gap in the spine, but no opening or sac on the back. The spinal cord and the nerves usually are normal, and there is rarely any displays of symptoms. The second type is closed neural tube defect. There is a malformation of fat, bone, or meninges. Again, there are little to no symptoms. However, there are some cases that result in incomplete paralysis with urinary and bowel dysfunction. Another type of spina bifida is meningocele. With meningocele, a sac of fluid forms through an opening in the baby's back, but the spinal cord is not pulled into the sac through the opening. Again, this results in little to no symptoms. However, again, there are cases that result in complete paralysis, causing urinary and bowel dysfunction. The fourth type, which is also the most severe, is myelomeningocele. When people talk about spina bifida, most often they are referring to myelomeningocele. With this condition, a sac of fluid comes through an opening in the baby's back. Part of the spinal cord and nerves are in this sac and are damaged. This type of spina bifida causes moderate to severe disabilities, such as problems affecting how the person goes to the bathroom, loss of feeling in the person's legs or feet, and not being able to move the legs, which makes walking difficult. This is also a life-threatening type. Impact on body structure and function. Walking and mobility are huge areas that are impacted by spina bifida. The area of defect and below can cause weakness and even paralysis. This causes walking to be difficult as well as getting out of bed and navigating the community. Next is orthopedic complications. This includes scoliosis, abnormal growth or dislocation of hip bone, and joint deformities, as well as muscle contractures and more. Next is bowel and bladder problems. There are nerves that supply the bowel and bladder that come from the lowest level of the spinal cord. This is often impacted in spina bifida cases and leading to dysfunction. Lastly is hydrocephalus. This is the accumulation of fluid in the brain. Often, hydrocephalus causes balance issues, shuffling gait, memory loss, as well as headaches. There are other complications due to spina bifida, and these include shunt malfunction, Chiari malformation type 2, meningitis, skin problems, and more.
Impact on occupational participation and performance. So, as we all know, participation is an important aspect to development. It contributes to life satisfaction, and it helps kids learn skills needed for the future. Through play, through activities, that's the way that children and younger adults really learn to develop skills that they would need in the future for not only things like self-care, but for other things like their academics as well. So it has been found that youth with disabilities participate in fewer activities and participate less often than their peers. So not only are they less involved in activities and the amount that they do, but they just aren't in activities as frequently as their peers that are their age. So participation can really be impacted by the child's functioning, and this includes their physical functioning, their cognitive functioning, and their communication functioning. You can think about how each one of these things might impact their participation in a different way. So, for example, it's important to consider hydrocephalus and how that may play a part. It can impact their ability of how they participate in different physical activities just based off of their limitations from that. And there's a certain age when bowel and bladder issues would really become a problem. It would be harder to plan out which situations you can participate in, and if something were to come up, would they be embarrassed if they were to have an issue with handling their bowel and bladder needs. For physical functioning, it's also important to consider any orthopedic complications such as scoliosis or any deformities, and how these would affect the ability to participate in the traditional activities we think of childhood, like any sports or anything that involves more physical activity. That may be more difficult depending on what the child has going on. And as for communication challenges, as you can assume, any difficulties with communication can impact social activities and the ability for the children to communicate with their peers, which can also make participation a bit more of a challenge. So on this slide, I'm going to be talking about a study done by Kelly et al. In 2011. So this study specifically looked at occupational participation and performance challenges for children with spina bifida. So the study was done with 64 children aged between 2 and 18 years old. So they were given the CAPE to look at recreation, physical, social, and skill-based activities. So this was a way to kind of evaluate how everybody was spending their time and seeing what activities that they were able to participate in. So the younger children, the ones 2 to 5, got the assessment of preschool children's participation, which is the younger version. So within the study, they only really looked at intensity, which is an aspect of the assessment, and this investigates how frequently or how often time is spent on a certain activity. And with the younger children, the information was given by their caregivers since they were too young to speak for themselves. And with the older participants, they were given their information was given via self-report. So as you can see on the slide, this is just kind of like the overall summary of some of the points of the study. So younger children tend to participate in more play activities, which is expected of their age. This is kind of typical. But then older children participate in more social activities. And overall, there was more participation in recreational and social activities than physical or skill-based activities, which kind of ties back to what we were saying in the last slide, where these physical activities can be a bit more of a challenge just from the challenges that occur with the impacts on the body structure and the function. So there seems to be a greater trend of participation within the social activities. And another interesting note is that school age appears to be the time when there's a decrease in physical activity participation. So this seems to really be the age where an intervention or some more assistance could come in handy to help bridge that gap and maybe have some adaptations in place to help these children be able to participate to the best of their ability.
So on the next few slides are common assessment tools that can be used with this population. The first is the PEDI, which evaluates functional skills and abilities in areas of self-care, mobility, and social functioning. So it can be used to identify possible functional deficits and establish treatment plans. It can also be used to identify treatment progress as well as recommend new areas of functional intervention. Then we have the WE-FIM, which is specifically for children, and the FIM, regular FIM, which is for ages 7 and up, which we all know assesses different areas of ADLs and IADLs for level of assistance needed for functional tasks. Then we have the ASK, the ASQ, which is a questionnaire that is filled out by the parents and scored by professionals, paraprofessionals, or clerical staff. It assesses 5 areas of communication, gross and fine motor, problem solving, and personal social, but can only be used from birth to 5.5 years of age. So this slide is a continuation of the previous slide, looking at more assessments that can be used with this type of population. Unlike the first slide, on this slide there are some assessments that look more into cognitive functions and behavioral functions, as well as quality of life. So the first assessment is the Trails Making Test B, which assesses working memory and task shifting capabilities. So this is looking more into cognitive functions. The Vineland Adaptive Behavioral Scale looks at adaptive behaviors in communication, daily living skills, socialization, and motor function. The Pediatric Symptoms Checklist is a screening tool for psychosocial factors, and psychosocial meaning the relationship between social factors that a child might experience in his or her life and how that impacts their thoughts and their behaviors. And this looks at the cognitive, emotional, and behavioral realms of that aspect. There's the Life Satisfaction Questionnaire 9, and then the Pediatric Quality of Life Inventory, which is a health-related quality of life relative to physical, emotional, social, and school functioning. Again, this is a continuation of more assessments that can be used. The PODCI assesses overall health, pain, and ability to participate, and in that assessment there's 8 scales that are looked at. And then there's the Craig Hospital Inventory of Environment and Factors, which assesses environmental barriers. Lastly, we have some more additional assessments that can be used with this population. Many of these assessments we've actually seen in previous courses and semesters. We have the AIMS, the AMPS, Berry VMI, COPAM, PDMS2, and the SFA. In summary, all these assessments are used to identify current functional levels in various performance areas, and this is building a foundation for us to be able to formulate an intervention plan for that child. Assessments are really used to gather a comprehensive image of a child's functioning and life skills and environment, so that we can build a client-centered intervention plan. Some of these assessments can also continue to be used throughout treatment to monitor progress or determine other areas that need to be addressed.
When working with children who have spina bifida, just as with any other client, it is crucial to consider both performance and context. 3 common approaches to intervention for this population include task-specific instruction, cognitive orientation to daily occupational performance, or the co-op approach, and family-centered functional therapy. Task-specific instruction assumes that a child will learn how to perform specific meaningful tasks efficiently, while also learning the underlying movement principles of those tasks. Thus, what is learned will carry over to other similar tasks. In the co-op approach, The therapist employs guided discovery and works in partnership with the child to facilitate development of skills through having the child problem solve and trial different global or domain-specific strategies in order to increase performance. This approach in turn increases the child's self-efficacy and their ability to generalize. The family-centered functional therapy approach is derived from dynamic systems theory. Dynamic systems theory examines how the complex interactions between a person, their environment, and tasks influences behavior. This approach has a strong emphasis on family collaboration. So the family may assist the therapist in identifying the child's interests, goals, and even help them to recognize barriers to success. On this slide, 3 areas of occupation that are commonly addressed in intervention when working with children who have spina bifida are identified. These areas include ADLs and IADLs, play and leisure, and social participation. As typical in OT intervention, when addressing ADLs and IADLs, our primary goal is to increase independence and quality of life. Common occupations addressed when working with this population might include dressing, bathing, feeding, swallowing, mobility, personal device care, sexual activity, and health management. As mentioned previously in this PowerPoint, children with spina bifida often lack the ability to control bowel and bladder functioning. Thus, addressing toileting needs in this population is of the utmost importance. As an OT, we may work with children to increase independence in self-catheterization and help them to develop bowel and bladder programs. Self-management of self-catheterization has been found to highly increase quality of life and independence for children who have spina bifida. As it is well known that play is a primary occupation for children, it is important that this be included in our OT intervention as well. Intervention in this area has been found to have positive effects on both the mental and physical health of children. When addressing social participation, it is important to be aware of the fact that children with spina bifida often report feelings of depression and isolation. The utilization of assistive devices has also been found to pose as a barrier to social participation for this population. We as therapists must help our clients to find ways to incorporate their devices into daily living and activities they find valuable. As OTs working with children who have spina bifida, we may at times need to provide suggestions for necessary environmental or task modifications. This may occur within the child's home, school, or in the community. For example, the installation of a ramp for a child who uses a wheelchair for mobility. Assistive and adaptive device needs is also included in our role as an occupational therapist. We at times may assist with device selection or fitting and will commonly assist in teaching children how to properly and safely utilize their device. Some examples of devices commonly used within this population include wheelchairs, augmentative communication devices, adaptive toys, and orthotics. It is important to be mindful that devices should always meet the family's needs and preferences. Understanding what the family is ready for and on board with is key for equipment being utilized. As many children with spina bifida may spend the majority of their time seated in a wheelchair, part of our intervention should also include preventing the development of pressure sores. As is typical in most OT intervention, we must also provide education. At times, we may be required to educate families, teachers, other healthcare professionals, and even communities on our clients' strengths and needs.
So some additional information about this population is that there's a lot of complications that are associated with spina bifida. Some of this can include shunt malfunctions or infections. Meningitis is common in children with spina bifida. Tethered spinal cord, sleep apnea, skin integrity can be a big issue, especially if there is some mobility deficits and they are in a wheelchair for long hours at a time. Pressure sores can become a big issue. Another common associated allergy is latex in children with spina bifida. As they get older, urinary tract infections can also become an issue, GI disorders, depression, and with more severe cases of spina bifida, learning disabilities can also be present. In conclusion, spina bifida can range from mild to severe and can affect physical and cognitive function. The degree of disability really depends on the size, type, and location of malformation. So this can vary from person to person. It also affects mobility and orthopedic functions, as mentioned previously. A common issue that many people with spina bifida have are bowel and bladder control issues. Depending on degree of disability, many areas of occupation can be affected and may need to be modified throughout the lifespan. There are many different assessments that can be administered to this population to build a comprehensive picture of the individual. This can be used as a basis for evidence-based interventions. This presentation is just a brief synopsis of spina bifida, and the references listed can be used to find more information.